بسم الله الرحمن الرحيم أرأيت الذي يكذب بالدين فذلك الذي يدع اليتيم ولا يحض على طعام المسكين فويل للمصلين الذين هم عن صلاتهم ساهون الذين هم يراءون ويمنعون الماعون.
Sadaqallahu al-Azim. Assalamu alaikum. Esteemed colleagues and distinguished guests, I welcome you to Annual Cardiology Update 2024, inaugural session titled Best and Worst Cases. This sessions aim to explore the spectrum of cases that define our daily practices, from triumphs that showcase our advancement in interventional cardiology practices in Pakistan to complexities that remind us of the continuous learning curve that is our field. I feel honored to introduce our esteemed panel of experts. Colonel Mujibul Haq, Consultant Interventional Cardiology at Heart International Hospital. Brigadier Nadir Khan, Professor of Cardiology at Armed Forces Institute of Cardiology. Sure, sir. Whatever you're comfortable with. Dr. Akhtar Ali Bandesha, Professor of Cardiology at Pakistan Institute of Medical Sciences. Your questions and our panelists' insight will foster a robust and dynamic discussions on lessons learned from our most challenging cases. So let us formally begin with the first presenter. Dr. Asad Riaz is the resident of interventional cardiology at Pakistan Institute of Medical Sciences. I welcome him for the first presentation.
Bismillahirrahmanirrahim. Good evening, everybody. I, Dr. Asad Riaz, fellow interventional cardiology from PIMS Hospital, Islamabad. Today, I am going to present the case of challenging angioplasty of right coronary artery. Actually, I was a second operator while this case was performed under supervision of Professor Akhtar Ali Bandesha. We had 76-year-old female diabetic hypertensive, have TVCADs. She was surgical turned down on medical treatment since then and now admitted with unstable angina. Core angio was done. We showed TVCAD with heavy calcium burden. RC engagement is a bit difficult because of its unusual origin, which is upward origin. Echo shows normal kinesis with normal ejection fractions, and labs are unremarkable. We had plan of angioplasties to RCA with rota backup. But we have difficulty with the guide engagement. Whenever we do try to engage the guides, it's buckle back and do not engage properly. And along with whenever it touches the ostium, patients do complain chest pain, ECG changes, and hemodynamic compromise. We switched back into the, we took the AL guide. We might have a better support so we can cross the wires. But we are unlucky, and we have again switched back into the Judkins right catheters, and we have took two wires, one workhorse wire, which is placed in the side branch, while we took the polymer jacket wire, which we have parked in the PDA. After that, we have prepared our vessels with semi-compliant balloons followed by non-compliant balloons at higher pressures. Once the lens is prepared, we put our second wire into the PDA for the better sports. Once we have placed our first stents, we have take out our gel wire. So we do not want to gel our wire against the calcified RCA. We deployed Science Expeditions 323 And here's what we had. We try to take a longer stand so we can cover our ostium and with the same category. What we had, we disengaged everything, we lost the wire positions, and then we re-engaged the same catheters. We able to recross two wires through the struts, and then we took the relatively two smaller stands with better deliverability to cover the RCF from mid to ostium. Here we took the Coroflex Isonew 328 to cover the mid portions. And followed by it, we covered the ostium with the Coroflex, which we took 3524. Post dilatations was done at 3515 NC at higher pressures. And here are the final results, which are pretty good results. What is the take-home message is some procedures doesn't look as difficult as they are. This case took us 2.5 hours with 350 ml dye consumptions along with exposures, radiation, 22 milligray. On the other hand, same day we did almost 9 other angioplasties with contrast average about like 90 to 120 ml contrast we used in those angioplasties with radiation exposure was like 275 to 415 milligray. So here I have a question that in these such type of cases, what options we can avail to gauge such type of RCAs and so we can proceed. Actually, rota was our backup plan because of the guide engagement. We could not able to perform the rota. We are afraid if we do the rota, we might hit the aorta because whenever we push the wire, the guide buckles back along with our wire positions lost. So we did not proceed, and we proceed this heavily calcified RCA without rota. So what we can do in these cases? Sir, please.
So your chief problem was guide engagement, not the calcium burden.
Yes, sir.
So you, at the end of the day, calcium didn't bother you. You stand delivery and all that. Did you have problem? Oh, okay, just the guide sport. So did you have more options of guide catheters with you?
AL1?
Yes, we took the implants, but it was not also engaging very well. So we had to take it from downside, and it was reaching there, but not getting anything. So even the wire was not going down. Right. So it was nothing, but it was everything. The problem was with it.
Got it.
Sometimes for the engagement of the right coronary artery, 3D guide catheter, you can somehow get it very nice and deep, and it is quite supportive as well, and it is quite easy to engage as well.
Sir.
So that could have been utilized.
That especially if it is coming closer to the left coronary
Yes.
artery, actually high
Yes.
takeoff.
Yes.
But
You can have even AL 0.75.
Yes,
yes, that we did not have the smaller.
Oh, yeah.
And once you have got the guide in, you can, and some part of the wire in, you can take a micro catheter and put a Grand Slam down, so that would sort of give an added support to the whole system.
Sure, sir.
That's what I was thinking, use of microcatheter. It's a combination of, I think, all the things together, because you had some calcium there. Did you ballooned it with NC?
Yes,
higher
sir.
pressures?
Higher
Actually,
pressures.
I missed a lot. That's why
Sir,
I'm not.
we did balloons to 5 followed by 3 or at 20, 22, 24, we went there at
So
higher
you did
pressures.
everything in terms of dilatation, but there was calcium, fibrotic element.
Yeah, exactly.
All other things there.
Yes, sir.
Certainly, then microcatheter do help. Now, newer technology of IVL is there. If you can't do rota, you can put in intravascular lithotripsy. That's expensive a bit, but it's an option.
But actually, the calcium actually was taken care of by the non-compliant balloons, and we were able to deliver one stent with 2 wires actually down in right coronary artery, but a longer stent was not going. That was the reason. And
But
then
actually, ballooning and radiographic images are not
Yes.
true representative of
Absolutely.
your lesion characteristics. Ideally, it would have been IVUS that guide you clearly what's happening there inside the vessel,
Exactly.
in the wall,
Sir.
lumen, adventitia, media, calcium status, arc,
Yes.
360,
How difficult it will
180.
be to take a
Yeah.
high-vis catheter or rota
yeah.
catheter actually
No, in the
with this guide catheter sport.
In this whole scenario, there's one thing more interesting. At what stage you lost the wire? After
Second
stent?
stent.
second,
wide
while
one.
we
You
are
had put in the first stent?
we have put the first stand which is smaller size, then
Yeah.
we took the longer comparatively, so we can cover with one stand from mid to ostium. Once we took that stand and we have lost everything.
You are very fortunate that you went in the right track, otherwise after balloon dilatation of that much
Yes.
severity,
Exactly,
you know,
sir, we are
3.0 at
fortunate.
2022, you have a volcanic eruptions in your vessels.
course.
And you don't know which channels you are going to get in.
Yes, definitely.
And another thing is use of a guide liner. Sometimes if the guide is not sitting properly, the guide liner sort of can help you there.
You can railroad on that micro.
Yes,
Exactly.
Yes.
Sir, guide
The
support.
point where we actually missed that was once we had put in one stand and one wire was behind that stand starts actually, we would not have taken that before we were able to push the second stand down line actually. That was a great sport, but we lost that, so we make these kind of mistakes and
Sir, good guide support is actually the cornerstone of all angioplasties.
Yes, of
And
course.
I think this was a beautifully done case. In the end, the result was excellent. Sometimes you'll have to do many unusual things also. Maybe if the first guide was not engaging, then you'll actually go up to the seventh French. And sometimes when you're placing two wires, you deliberately jail a wire in the distal stand so that you can track the other stand.
yes.
And even you have to go a distal anchor, use a distal anchor balloon to actually pull in the other stand. So there are multiple things, and unusual circumstances would actually require unusual solutions to handle them. But this was a beautifully done,
Sir,
Caspian.
thank you so much, sir. Sir, thank you so much. Thank you.
Thank you, Dr. Asad. Now I invite Dr. Imran Iftikhar, who is Assistant Professor at RIC, for his presentation.
जी अस्सलाम वालेकुम एवरीवन अस्सलाम वालेकुम एवरीवन माय नेम इज़ डॉक्टर इमरान एंड आई एम वर्किंग एज एन इंटरनेशनल कार्डियोलॉजिस्ट एट RIC Rawalpindi. Today I'll be discussing a very interesting and a challenging case with quite a few complexities and quite a few challenges, and I'll walk you through that how we tackled those challenges. First, a brief history of the patient. An 80-year-old female hypertensive diabetic. She presents to the emergency department with complaints of chest pain and right-sided weakness for last 3 hours. And on her examination, her blood pressure was 145/90, and she had right-sided hemiplegia with last seen by our time was 3 hours ago, and her NIHSS was 16, pre-stroke MRS was 0. We did her CT brain plane. There was no intracranial bleed, and we did the CT angiography of the cerebral vessels, which showed subtotal occlusion of the left internal carotid artery from the ostium. Her ECG was done, and it revealed inferior wall STEMI, and her echo was done, which showed an ejection fraction of 45% with no clot in LV. So here are the dilemmas and questions that which organ should we salvage first? Either should we go for primary PC of RCA, or should we deal the subtotal occlusion of the left ICA? And the another question is that how to manage the anticoagulation and what antiplatelets should we give and when to give the antiplatelets. So since the patient was hemodynamically stable, there were no electrical instability, so we proceeded with the cerebral angiography, and after taking SIM2 catheter, we engaged the left internal common carotid artery, which showed an subtotal occlusion of the internal carotid, and there was critical osteal disease in both the ostia of the external carotid and the left internal carotid. So this is the angiogram, and this is the diagnostic angiogram of the aortic arch. You can see there is a the origin of the left common carotid and the brachiocephalic trunk, they both are arising from the same trunk. So this is an example of a bovine arch in which both the left internal carotid and the right system, the brachiocephalic trunk, they have a common origin from a common trunk. So this was a bit challenging since the bovine arch poses significant difficulty in engaging the common carotid, left common carotid. So so we tried initially with the diagnostic catheter. We were able to take the diagnostic pictures, but when we tried to take the Fabuki sheath, which is a 6 French sheath, 90 centimeters, we were unable to cross the, negotiate the bend of the aortic arch. You can see the difficulty. We changed the normal exchange wire with a super stiff wire to have a better mechanical support, but we were unable to cross the aortic bend into the left common carotid artery. Then we switched another strategy. We took a aspiration catheter within the Fabuki sheath, and we parked the aspiration catheter distally into the common carotid, but when we tried to track the Fabuki sheath into the internal carotid, it would prolapse down into the aortic arch. So we were having difficulty in engaging the left common carotid. So due to the bovine arch, we shifted the access site from femoral to the brachial. We took a 6 French brachial sheath, and from the brachial side, we tried to engage the left internal carotid common carotid artery. So we were having the same difficulty as in the femoral access. We were unable to cross to negotiate the bend of the aortic arch. So we tried multiple wires as well. We tried taking up the 2-3 coronary wires into the common carotid, and then we tried to navigate our Fabuki sheet over it, but we were unable to do so. So since we were losing time, and you know that time is of very great importance as far as the mechanical thrombectomy is concerned, and we are losing, with every minute we are losing significant numbers of neurons. So after that, we decided to consult our senior interventionist, and after discussion, we went for a direct carotid puncture, so which was done under fluoroscopic guidance and with the help of a 4 French radial sheath. And direct carotid puncture can be, it is done either under fluoroscopic guidance or with the help of ultrasound Doppler. And we do it medial to the sternocleidomastoid muscle, lateral to the cricoid cartilage, just 2 to 3 centimeters above the clavicle. And one should remember that it can lead to serious hematoma formation as well. So to tackle this, we had to intubate the patient first. So after direct carotid puncture under the fluoroscopy guidance, we parked the Fabuki sheet into the left common carotid artery. So this is a nice little article about direct carotid puncture. So it is a well-established and well-documented, well-published technique as far as the safety of the direct carotid puncture is concerned. So after taking Fabuki sheath, we crossed the lesion with a coronary wire, and then we did an aspiration over here to debulk the lesion at the ostia. And after debulking, we put a distal protection device into the internal carotid distally, and then we, after pre-dilatation, we did the stenting of the ostia of the left internal carotid with the 8.6 into 30 millimeter exact carotid stent system. And you can see on the left side a great result. And the distal vasculature, middle cerebral artery and the anterior cerebral artery, they both were patent with no disease in them. So these are the still images. You can see well-perfused cerebral circulation. So what antithrombotics should be given? Since it's a case of acute ischemic stroke, and there is risk of post-stroke hemorrhagic transformation, anticoagulation is contraindicated. And the antiplatelets would have to be given after we finish the procedure, and we gave patient aspirin and ticagrelor through the NG. But since it had to be given after the procedure, after the completion of procedure, we gave half dose agrastat during the procedure to avoid any stent thrombosis. Then we return to the coronaries. This is the left system showing critical disease with the cross-filling of the RCA. And on left side, you can see that there is total occlusion of the RCA from the ostium. Initially, there was difficulty in crossing the lesion with a normal workhorse wires. Later, we shifted to fighter, and we were able to cross it. And after pre-dilatation, we were able to stent it with the 275-34 Resolute Onyx stent, and we had a great result after stenting. So it seems that we have crossed the finish line, but difficulties were not over yet for us. We managed the carotid access site with the gentle manual pressure for around 15 to 20 minutes. And we did the pro glide at the femoral access site. But when we removed the brachial sheath, there was no blood or no back bleed from the brachial artery. So it showed that patient had acute brachial occlusion. So we confirmed it after with the help of Doppler as well. So after consultation with the surgeon, we went for Fogarty of the brachial artery. You can see the Fogarty procedure being done. And it was successful. Both the ulnar and brachial, they were ulnar and radial artery, they were palpable after the procedure, and you can see the good oxygen saturation on the right, from the right hand. On the left side, you can see. And this is the patient after post-procedure. Her GCS improved, she was extubated. Her power of the right side improved. In the right arm was 2/5 and 5/5 in the right leg. So take home message, switch strategy timely. Remember that time is brain. Around 1.9 million neurons are lost with every passing minute. And direct carotid puncture is a feasible alternative of approach to transfemoral or brachial access when there is unfavorable arch type or there is carotid tortuosity. And always check the access site post-procedure for any complications. So I would like to end my presentation with this quote: success is not final, failure is not fatal, it is the courage to continue that counts. Thank you.
डायरेक्ट कैरोटिड जो पंचर किया, ये अल्ट्रासाउंड गाइडेड था या ये फ्लोरो गाइडेड था?
It was fluoro guided, sir.
So how much it take from starting the procedure for like carotid intervention to finally intervene?
Sorry, sir, I couldn't get it.
How much duration does it take from starting the procedure of carotid intervention to finally
Till we finish. So till we have done the right coronary system, it took us around 3.5 hours, and then you can add up around half an hour to 1 hour more for Fogarty and later on. So it was around.
In the meantime, haven't thought of doing RCA, at least maintaining flow there and then coming back again to carotid?
No, we did.
After that, you went to take care of inferior MI.
So, sir, the idea is that if the patient is hemodynamically stable, you first go for the brain, and after doing the brain, salvaging the brain, you can do
that is a standard. But if it's you're forcing that it take a lot because you have anomalous and other things, and your preliminary effort were really not succeeding. So at least how much it take to maintain a flow in RC and then come back again?
You are right. We could have
just POBA maintaining a TIMI3 flow there and then coming. You were lucky that she wasn't giving you VF, VT or any hemodynamic instability. But in acute MI, nobody knows what happens next.
What happens next?
That's just a thought.
Yeah, we could have
it's
done
not
that.
a standard rule, it's an option. Just a food for thought. You could have done that if you are getting late in intervening for reperfusion of brain, at least reperfuse heart and then come again to brain and do all other things.
It's a good idea, and we could have also done that as well. So since we had
Second is, if really you are unable to do anything, can TPA be a option for both?
So
it's 80-year-old lady, difficult, but you're unable to do, you're losing time, can't intervene there.
So the indication of TP
because
is that
3 hours
sir,
within a window of that.
I get it. So the indication of TP is that you do it within 4.5 hours. So patient are already, her last seen well time was around 4 hours back. So it took us for CTA and CT angiography to do, it took us around 35 minutes. So she was
out
TPA,
of that
yeah,
window.
she was out of TPA window.
Yeah, it's an excellent case. And I think it's the first in man experiences which we're seeing. And it's just so innovative. So there's no right or wrong because they are writing the script. So if it works, that is the script.
Sir.
And initially, you know, we used to, cardiologists do the carotids, but initially the neurosurgeon would do a direct puncture.
Yeah.
And that's how they would take a picture. So it's nothing new, and they would do a tactile puncture. It's a great case. About the brachial occlusion, we did a brachial, lots of people are doing brachials, but it has a lot of potential for problem. And because it's an end artery, it can be very painful, unlike a occlusion here. So once we did in Forging Foundation, a brachial, and I came out of the ward and this woman was crying that she had a lot of pain and the hand was blue and immobile. So we asked the surgeon, and in the meantime, I put a little oxygen there, and I could feel the pulse, but it was not flowing. So I started massaging it, and I kept massaging because my thought was that it's a fresh thrombus, so whatever it is, we can probably squash it. And as I was massaging it, the pulse started coming, and she got the whole arm function back, the pulse got back, the flow got back, the days became pink, and you know, the vascular surgeon came and he said, it's all done. So I think that's something which you must also think, that if you occlude an artery, initially where the thrombus is there, just by massaging it, we have a potential of restoring the flow. But of course, get the vascular surgeon, but that's a quick remedy.
But you had this femoral axis as well, you had left radial axis as well. So when did you get through this brachial?
So for mechanical thrombectomy, we usually, if the femoral is not,
but you
it
have
is difficult.
punctured it actually. You tried to take your sheath, which was unsuccessful, from the femoral.
So first we tried with femoral, we were not successful, then we tried the brachial route.
So radial
is very difficult to went through.
I remember Nadir Saab was in Lahore when he did, for me, a first carotid with a radial in a bovine arch. Yeah, and that was really phenomenal. I was very jealous.
And actually, on the look of it, this external and internal carotids appear to be a thrombotic occlusion rather than chronic atherosclerotic.
It was, there was acute on chronic occlusion because we aspirated, but there was still critical lesion after the aspiration catheter. We could see that there is a still critical osteal lesion, and even after pre-dilatation, it would recoil back, so we had to stent that after that.
Got it.
That was the reason.
I think we're running short of time the way moderator is coming.
Thank you.
Very insightful indeed. Now I invite Dr. Zubair Ahmed from Wazirabad Institute of Cardiology for his presentation.
Bismillahirrahmanirrahim. My name is Dr. Zubair. I'm working as a senior registrar at Wazirabad Institute of Cardiology. In this case, my senior Dr. Amr Sadiq was there, who is an assistant professor working there. The case is a 49-year-old male, hypertensive, non-diabetic, presented with recurrent episodes of angina. EC showed non-specific ST changes in precordial leads. He had ejection fraction of on 60% on transrexus echo. His labs were normal. He was on optimal medical therapy, but still symptomatic. He was doing dual anti-angina drugs. So his elective coronary angiogram was performed through right radial approach, which shows critical osteal LMS disease extending into mid part, but angiographically uh, LAD, distal part of LAD, or ostium of LAD, circumflex, as well as right coronary. As you can see in this images was look non-obstructive, and there was no significant lesions found in them. This is right coronary image. So we calculated his syntax score, that was 12, and according to syntax score 2, his score was 18.9 with PCI, the 2.7% 4-year mortality with 19.3 score with cabbage with 2.8% 4-year mortality. And patient was counseled about the cabbage, but he was not willing for the cabbage as well because of his low syntax score. It was decided to go for the aorto ostial LMS PCI. Uh, uh, we took right femoral approach with 7 French sheath and EBU 3.57 French guide, and engaged the both LAD and circumflex was wired with BMW workhorse wires. But on engagement, the patient started to complain chest pain, and its pressure was also damped. So we immediately pre-dilated the lesion with 4.8 U for a NC balloon. After that, we placed a drug-eluting Promus Elite stent of size 4 into 12 millimeter, and then we check in very different projection. As we know, the best view to place the ostial LMS stent is iliocranial view, and then we co-limited the projection in LO10-10 view. Then we reconfirmed and placed stent. After placing the stents, you can see the results. It was a crossover stenting from ostial LMS to LAD. Initially we were of plan to perform the IVUS pre-stenting IVUS run, but unfortunately the patient was very symptomatic, so we decided against it. Then we performed our first run of IVUS. You can see, although the distal vessel LAD was looked fine on angiographic view, but there was a plaque in LAD as well as the LMS, and the stent was well opposed. We achieved very good MLAs at distal end and proximal part. At distal reference vessels, the MLA was 8.3, and at the ostium at the LMS, the MLA was 10.32. But there was a local under expansion, so we post-dilated the lesion with 4.5 into 10 millimeter NC balloon, the distal part, and we took 5 into 8 millimeter another balloon to post-dilate the ostium and flaring of the lesion. So this was the final IVUS region. We did perform another IVUS run after post-dilating lesion with 4.5 millimeter NC balloon, but this was the final result, and you can see the very good results, very good covering of the ostial LMS. ये stop कर सकते हैं? बिल्कुल एंड पे स्टॉप कर दें. आगे चलिए, आगे बस ठीक है. ओके, द फाइनल. So the final MLAs that were achieved at the distal reference vessel was 12 millimeter, and at the ostium was 14.48, which was well adequate. And so this was, you can see the last projections for the final results. This was all about the case. I have a few tips and tricks around osteal LMS PCI that would like to explain with questions and your suggestions.
Very good case and very comfortably done actually, and after IVUS you used a bigger balloon and dilated to the maximum, so wonderful. And Punjab government is doing a lot of things, Wazirabad Institute of Cardiology and rest of the cardiology, and today I was in a meeting and they were showing the hospital revamping in whole Punjab, actually in Bhakkar, in Mianwali, beautiful buildings and infrastructure, and then they are equipment is excellent. So.
जी आवाज आपने बड़ा अच्छा किया है, you did very well, but the thing is whenever you are attempting an osteal disease like this one, you can put another wire which hangs outside the vessel.
Okay, sir.
And that will help you because that will not damp the pressure.
Okay, sir.
Otherwise the pressure can damp, and that is the time when some problem can happen.
Sir, actually we did a very deep literature review before doing this procedure. If you can, this slide दिखाइएगा.
Third wire it can be put which should hang outside the left main,
Sir,
into the aorta.
Sir, although it's a very good thing to do for doing, but we already had 2 wires placed in LAD and circumflex. When I just follow Elias and from his lecture, and he told is one of the lecture that if sir, if the wire is just next to the ostium, it's a very good option. But if the wire is just not not very close to the
Yes, we can see it.
sir, if the wire is not very close to the this part, so this can lead to stent placement in the aorta. So that's why we could have gone for that, but for this reason, and also we had placed 2 wires, and we didn't want to place a 3rd wire and put all over. We wanted to just keep our eye on main position.
Yeah, but it is generally accepted as more.
अरुण साहब आपने ना बड़ा अच्छा पॉइंट बताया, but he described it very well कि हर केस में नहीं. I mean sometime when you got
नहीं
a
हर
rocking.
केस में क्यों नहीं? You tell me.
सर मैंने कभी भी नहीं इस्तेमाल किया.
आप ना करें, but this is the standard practice.
नहीं सर ये
If you are doing an osteal left main, it is better to put a wire which should hang outside, क्योंकि वो आपका damp नहीं करेगा.
सर वो आप ना वायर से कंट्रोल कर लेते हैं.
नहीं, firstly,
अच्छा हम इससे चल
which guide you have used in this?
7 French.
We use EVO 3.5.
So that's again a very important point when you're doing osteal left main, and there wasn't any issue of support or bifurcation or two stent. I don't know why 7 French, because you have to keep your French, because you have an osteal disease. The bigger the French, more will be chances of damping pressure and difficulty in engaging. And EBO itself is difficult to engage and re-engage and dislodge from the ostium. It's good to have JL 6 French easily manipulated at the ostium. Once you want, your pressure is damping, you can take it out, see what's happening there. And ideally, you should have done IVUS before the case. Because
Fawad bhai, I mean, all relevant points.
And to look out into the extent of you, because ostial LED had a plaque as well. So if this ostial left main plaque is extending all across left main into LED, then you may have thought of stenting from ostium to LED as well. So it gives a fair amount of idea what to do with the anatomy in this situation. Its case was done very nicely, there's no doubt about it. But these are few technical points. One can opt.
Sir, you are very right. Actually, we didn't have JL7 French guide, so that's why we didn't.
Proper Pakistani majboori.
Again, Fawad bhai, we never used anything but a supporting catheter. And using 7 is not a problem for us. I mean, you can control the movement in and out with a wire in there. And I think when you want to do a left main IVUS, it's always a good idea to pre-dill, because if you're going to dampen it further with 2 wires in there, patient will become unstable. You know, especially ostial. So pre-dilate, and then you can assess with IVUS, because you need to make sure that the flow is made. So I think you did a wonderful case, and really.
And when pressure was damping, you ballooned straight away the 4.0. I have thought of making a place and then putting an IVUS and seeing the things, and then finally deciding about how far you have to go for pre-dilatation.
So यहाँ पे ना एक और चीज़ आती है कि equipment का कितनी availability है. Like अगर आपने stage wise ऊपर जाना है, तो I mean I can understand with today's constraints in health card and all. जैसे वो ways that Waleed Abbasi, he did a culotte with 3 balloons. I mean, it's amazing. So people learning how to do with less equipment.
That's a good point, but the JL one was also a nice point. If you use a JL, especially in ostial disease, left or main ostium.
अपनी preference है
JL.
हर
इसमें
की.
सर personal experience is very important.
हाँ, लेकिन this is what is recommended.
हाँ जी.
So ये कहाँ recommended है?
तो मेरे ख्याल में आपको नाइट्रेट जरूर देनी चाहिए.
Sir, we,
because
sir, this angiography was done in February, and that time we did div nitrate. So patient, we do try to clear that point at that time, and even putting on dual anti-anginal drugs, he remained symptomatic, and one of his ECG showed dynamic ECGs, although the rest ECGs was okay. So we were very sure that this is not small, this is disease.
Secondly, जो आपने slide दिखाई है उसमें one was a separate technique जिसमें वायर बाहर है और दूसरी जो थी वो ज़ाबो टेक्निक है.
Yes sir.
ये practically करना मेरे ख्याल में बहुत ही मुश्किल है और बहुत ही cumbersome है. अगर IVUS ना हो और patient symptomatic हो तो putting in a stand in the right view and then doing a port puff which was designed by probably the boss, वो शायद ज़्यादा बेहतर है. But this was beautifully done. IVUS भी बहुत अच्छा है. Excellent.
Sir, I have just one more point for
Sorry, I met Zabo once, and I talked about it. He said that it was just a crazy technique. Even I've stopped doing it. So it's not a, because if you damage the balloon, it will be disaster.
Thank you.
Thank you. Now I invite Dr. Waleed Hassan, Fellow Interventional Cardiology at Forge Foundation Hospital.
Bismillahirrahmanirrahim. I'm Dr. Muhammad Waleed Hassan. I'm a Registrar Cardiology and Fellow Intervention Cardiology from Forge Foundation Cardiac Center of Excellence, Rawalpindi. Today, I'll be presenting an interesting and challenging case that we encountered a couple of months ago. So my patient is a 75-year-old frail lady, known hypertensive and diabetic, with history of mucoperiodontoid carcinoma, treated by radiotherapy, and she's currently in remission. She was admitted first with us with non-acylation MI in December 2022. On admission, she was widely stable. Her general physical examination and systemic examination were unremarkable. Her lab investigation revealed an HP of 11.5. Serum creatinine was high to 20 micromole per liter. ALT was normal, and her hepatic screening was negative. Her ultrasound KUB revealed grade 2 renal parenchymal disease. Her echocardiogram revealed an EF of 45% with inferior and inferior wall hypokinesia. A nephro review was sought after for deranged renal profile, and she was advised conservative management and a moderate to high risk for CIN. After prehydration and normal saline, her serum creatinine improved to 140 micromole per liter. So we did a coronary angiogram with limited dye from right radial approach. This is a diagnostic coronary angiogram. As you can see, there is a lot of calcium on the left system. The left main has critical disease at the mid and distal course. The circumflex ostial has also critical disease, and there is some also critical disease in the proximal course of the circumflex. The LAD had probably moderate to severe disease, and it was diffuse from mid to proximal to mid course. And you can see there is some cross-filling of the right system. The LV was fair. The RCA was totally occluded from the ostium, and as you can see, there was no guide support of the on engagement of the RCA. So she was advised cardiac surgeon review. The cardiac surgeon advised her high risk of CABG, but during her workup for CABG, her ultrasound carotid Doppler revealed more than 70% stenosis in the right carotid artery. So the surgeon deemed her very high risk for CABG and advised her medical therapy. She was put on maximum anti-anginal therapies, but she had recurrent admission with us with unstable angina. Her CT carotid could not be done because of deranged renal profile. So we did a MRI carotids, but MRI showed a limited study and normal carotid, which was the findings were different from the ultrasound carotids. The patient was again admitted with us a couple of months ago with non-ST elevation MI with ongoing chest pain. Her fresh echo revealed an EF of 45%. Her labs were normal except for a raised serum creatinine of 130 micromole per liter. So the question was what to do next, as the patient had already been at surgical turndown, and she had recurrent symptoms of angina almost on the daily basis. She had multiple episodes of angina. So we decided to proceed with the high-risk angiogram and deal with the CT or RCA first, and then proceed afterwards. So we decided to proceed with a carotid angio and followed by a high-risk PCI with anesthesia cover. She was well hydrated before the procedure, and all the CIN protocols were followed. Her serum creatinine improved to 110 before the procedure. We took the femoral approach. We did ultrasound-guided femoral puncture. The fresh diagnostic angio showed almost similar disease in the left main. The circumflex ostial disease seemed to have progressed. As you can see, some haziness in the ostium of the circumflex. The LAD disease seemed to be as before. The RCA was totally occluded as before. The left common carotid artery has moderate to severe disease extending into the internal carotid artery. The right common carotid artery had critical disease at the bifurcation extending into the both internal and carotid arteries, but she was asymptomatic, so we decided to leave it as such and come after for that afterwards. So as per plan, we decided to go for the CTO RCA first. We took a GR4 catheter, but it did not have any support, so we shifted to the XB RCA catheter for the better support. It did provide us better support, but the wire could not pass. We escalated the wire up to the Gaia third, but still we could not pass the wire. The patient started having chest pain on the table, so we decided to leave the RCA and go for the left system. As the diet up till now had been used up to 100 ml of dye. So we took XB3 catheter for the left system. We parked a run-through wire in the LAD, and we crossed the lesion in the circumflex with the pilot 200 with the help of a microcatheter. And the run-through wire could not be passed. So we exchanged the wire with the run-through wire afterwards, after passing the lesion. We pre-dilated with first with 1.215 semi-compliant balloon, then with 220 semi-compliant balloon. After preparing the lesion, we stented the lesion from the left main to the circumflex with 338 stent. And then we post-dilated with 3 to 5, 20 NC balloon. And we did a port puff, as you can see here. This is the post-stenting picture. You can see there is some haziness at the outflow here, here, and here. So there was some disease left, so we decided to stent it as well. We took a 275 15 stent and stented this lesion and post-dilated with 3 to 5 20 non-compliant balloon. And then we did a port with 4 12 balloon, and we did a port puff technique. There was no downstreaming of the dye. This is the final picture. The circumflex looked good. We were still not sure about the LAD lesion, so we did a FFR, which I'll show later. We did an IVUS for the circumflex. You can see the stent seemed to be well approximated throughout the course. There is some calcification throughout the course of the vessel, but the stent seemed well approximated. Here. So the stent seem well approximated. As I was said, already shown us. This is the MLA of the left main, which was 12 millimeter square. We did an FFR of the LED, which came out to be 0.8, which were borderline. So and the patient's symptoms had settled up till now. So we decided to leave the LED medical. And up till now, a total of 350 ml of dye had already been used. As we do in all the femoral punctures, we take a bladder picture at the end. The patient remained hemodynamically stable and pain-free post-procedure. There was no excess site complication. We kept her on IV hydration for a couple of days with high dose of statins, as we do in all our patients with CIN. We discharged her after a few days, and her last creatinine was 120 micromole per liter. So the take-home message from my presentation is that in some patients with old, frail patients, especially with renal derangement, limited intervention is sometimes a better option than going for the total revascularization. And the port puff technique, it can be an alternative to IVUS when the IVUS technique is not available, especially in those centers. I thank you very much.
A wonderful case. And as you mentioned, she was a very frail lady, and this is actually a master class. So because you are not only handling her from outside with a very delicate hands, but you are treating her with balloons and wires and so delicately, because to look at her coronaries, you think that the next balloon inflation and she will rupture actually. But it was wonderfully done and beautiful case.
Thank you, sir.
There is a concept of partial but adequate revascularization. And because the right was totally blocked and the circ had critical lesion, the LED looked critical, but we thought there was enough blood going through it. So because the introlateral surface was like totally ischemic, so we thought that if we put the stent left main circumflex with limited dye, we can probably use less dye and just do a crossover stenting, and we'll see what happens to circ. And our plan was that if it came out as critical, we'll come and stage and complete it into a culotte. So she was very pain-free, and I think there was an interview also that we took a lady, and she was pain-free for the last couple of months now.
Sir, what I have seen is that limited angioplasty probably is better in these patients. And even if there is a lot of disease downside, if you put a one stent upstream actually, so that the patient, they become very good symptomatically, and the vessels, afterwards, they reform themselves lately. So limited angioplasty is a very good option, I think, in
actually
these complex
you may
cases.
call it limited, but you can also say staged.
Yes.
At this stage, you think while the RCA is almost irretrievable, and you look for the circumflex system, and that is probably the culprit producing angina and all that. And you made her life comfortable. When it comes to next, you can always deal with the LED. So you have limited at one time, but you staged at the same time.
Right. I think wonderfully done case, but in patients who have chronic renal failure, there is an accelerated atherosclerosis. What is going to be the fate of this stent in the long term, number one? And when you talk about high dose statins, what do you mean by that? What is the high dose?
Sir, we give atorvastatin 80 mg.
Pardon?
Atorvastatin, sir, 80 mg atorvastatin.
Which is more safe, rosuvastatin or atorvastatin in chronic renal failure?
Sir, rosuva is better, but in patients with CAN, atorva there was some data that showed atorvastatin to be better in a patient with CAN.
Can you combine atorvastatin 80 milligrams with ezetimibe 10 milligram and get better results
yes,
in
sir.
such a case?
Yes, sir, maybe. Yes.
Excuse me.
This is a very beautiful question actually, which Professor Qureshi has put in, because nowadays we have a combination available in the market where they have added ezetimibe with 10 milligram of atorvastatin or rosuvastatin or 20 milligram like that. We had a discussion on this in sometime previously as well, because the guidelines so far, they say that the ezetimibe should be added into the treatment line only once maximum statin therapy fails to reduce the LDL cholesterol less than 70 or 60, whatsoever the target is. But there is a point that the people who do not reach to that level and who eat a cholesterol-rich diet or are a bit better eater actually, or worse eater. So if we combine ezetimibe with a moderate dose of statin, the LDL reduction may be better because there will be some, the ezetimibe, it takes care of the absorption of the lipid from the gut actually. So less absorption and some effect by the statins as well. So the combination in these kind of patients. But if it is an 80 years lady, I don't think ezetimibe will be of any benefit because at that age, eating cholesterol-rich diet, it's not a problem.
Actually, let me say a few words.
Sir.
The needful was done.
Yes, sir.
Well done.
Right,
but in people who have complex coronary artery disease like this one, and elderly especially, who have got other comorbidities as well, even if you have not found out, they definitely have. There might be kidney involvement, there might be lung involvement, blah, blah, blah. So these procedures should always be staged. Because you are saving the patient, you are actually not a mechanic. You are a clinician. And what I do, I always stage these procedures if it's needed.
Sir.
But whatever you have done, I think it's wonderful. You have given a new hope and time to the patient, especially with this age and a complex picture.
Right.
Patient.
There's one question.
Sorry.
I think he's
Sorry.
Thank you, sir. Dr. Hamza Ghori here. Please go ahead, sir.
No.
Okay. So, like always, it was a wonderful display of technique, and I think we were having a similar kind of a discussion the other day on the Masters regarding the CTOs and the donor vessel and the importance of paying heed towards the revascularizing, especially when we are addressing the donors. So in this case, I think the CTO of RCA, and especially when there's a disease of the LAD, so yes, the CTO was attempted, but there was always a point of addressing the left system first. However, when you have the opposite of this, and when you have an RCA, which is a donor vessel with a disease supplying the LAD, which is a CTO, then obviously it becomes more important to secure the RCA, go for the CTO of LAD, and just because of the territory that it supplies. So I think in such cases, what would be the preference of the panel here? If you have an RCA CTO disease in the left system, you would go for the left system, or you think that RCA CTA still has some importance and going for that would be first importance, or at least it should be tried first to see how the patient fares, just like we did here.
It's a tricky question to answer because the scenarios so many, which is a dominant vessel, which is larger vessel, which is a viable area, what is easier. But if you have sort of a non-viable large area, which may be getting, it's akinetic, it may be when CTO cannot be retrieved, but I would first of all try and do the CTO if possible. But if the patient is very unstable, then like in this situation, we turned around and did the feeding vessel. So preferably, if the patient is like a surgical turn down, if it's a surgical turn down, then you have a license to do a lot of things. You know, you must take the patient into confidence. So, but there's any remotest possibility of a bypass option, then I would do the difficult one first. If I can't do it, I didn't send him for surgery. But if it's a surgical turn down, then you would maybe do the easier one first and then go for the CTO. There's no real combination. Sometime it may turn down to which guided did the fellows put in, you know. It could be as bad as that.
So exactly this kind of patient here, we are doing a palliative kind of thing. So would RCA already collateralize intrasystemic from other side as well? So I would have tried RCA first. I would have taken care of that LCX. So whatever I think is the main vessel causing ischemia to this lady, just take care of that and then come stage again to see what happens.
My comment about the staging is not like surgeon. If he's opened it, he has to fix everything. It's like akin to a dental treatment. Open your mouth, there are problems here and there, but the worst problem is a particular tooth. Do the job, finish it. Again, you can have an excess, which is almost non-traumatic. So access site is no problem. So staging is no big issue. Yeah.
Thank you very much, sir.
Please welcome Dr. Hafsa Liaquat, Resident Cardiology at Lady Reading Hospital.
Assalamu alaikum, everyone. Bismillahirrahmanirrahim. Thank you so much for giving me the opportunity to present my case. I am Dr. Hafsa Liaquat, postgraduate cardiology resident, Lady Reading Hospital, Peshawar. The topic of my presentation is out of frying pan into the fire. So our case is a 42 years old lady who presented to the outpatient department of Lady Reading Hospital with chest pain on exertion for the last 2 months, which increased in intensity over 3 days. Her past medical history was significant for hypertension for the last 4 years and diabetes mellitus for 9 years. She had poor medication compliance. ECG on arrival showed ST segment depressions in anterior leads. Along with ECG, other lab parameters were also taken. Among them, cardiac markers were raised. Echo showed no renal wall motion abnormality and LV functions were preserved. She was diagnosed as non-ST elevation MI. We suggested her admission, but she left hospital against medical advice. At this time, we wanted to admit her and go for invasive strategy later. Later, after 2 weeks, she presented again with typical chest pain. Her echo showed anterior hypokinesia at this time with an ejection fraction of 36%. It was then decided to go with an invasive strategy and treat her as an acute ST elevation MI. This was the ECG on the second visit. The next step was coronary angiography, so we proceeded with that. So this is an AP caudal view. System has been engaged to right radial approach using 6 French catheter. As you can appreciate, the LMS seems normal. LAD is subtotal. Circumflex is running smoothly, it's normal. And diagonal is having 80% disease. Further orthogonal projections were taken to make the lesion more clear and to confirm our lesion. Circ is a dominant vessel, mid portion 80% diffuse disease. Sorry, RC I meant. The next step was angioplasty of the culprit vessel. So for proceeding with the angioplasty, we wired the LAD with BMW guide wire and parked distally. Another wire in major diagonal can be appreciated. Okay, this is the, you can say, the point which changed our strategy. Looking at this image, what do you think would be the next strategy? As we can appreciate that this is a bifurcating lesion and following Medina 111. It's a true bifurcation, and then among true bifurcation is a complex true bifurcation. The side branch is a significant vessel having significant disease. And complex true bifurcation based upon the definition criteria fulfilling 1 major and 2 minor criteria. Having said that, further decision will be taken upon the angulation between the main vessel and the side branch. So, okay, you can have the pointer. Okay, so you can appreciate that the angulation between the main vessel and side branch is not 90 degree, so T stenting is out of option. It is not between 70 to 90, so TAP is all sort of questions. We are left with either going for Q-LODs or DK crush. The vessel diameter of the main vessel and the side branch are almost equal, so we proceeded with the Q-LODs technique. We pre-dilated the lesions, first of all pre-dilatation of the side branch, followed by pre-dilatation of the main vessel proximally. First stent was delivered and deployed in major diagonal. This is Promus 3x32. Post-dilatation of the stent can be appreciated. Distal optimization was done. This is the first proximal optimization technique for proper position of shunt struts, followed by adjuvant ballooning with NC Sapphire. So POT was done to prevent abluminal stenting, as you already know that. So rewiring of LED was the next step to the distal shunt struts of stent in the diagonal vessel. This was dilated with sapphire. Shunt struts are dilated in the main vessel. This was followed by removal of the jail wire and second stent delivery and deployment, which was in 2.75 into 18 in major LED proximally. This angiographic clip is demonstrating overlapping of the shunt struts, and kissing balloon inflation was done. When stunts, balloons in both the stunts in the main vessel and side branch are simultaneously dilated, so it increases the blood flow, increases the position of the stunts to the vessel wall. This is the second proximal optimization technique. This was our final result. TIMI flow 3 achieved and anatomy was restored. On a follow-up visit, her echo showed improved LV functions with an ejection fraction of 60%. So it was a success in her case. This is an echo showing improved LV functions. Here's a short quiz for you. It can be a recap for my presentation. So we had a 70-year-old man who was undergoing LED stenting with a good size diagonal at an angle of less than 60 degrees. The operator wired the LED and diagonal. The distal vessel and side branch are not equal in diameter. The operator selected to go for provisional stenting. The procedure became complex when a side branch occluded. The operator did POT in the main vessel, followed by KBI and re-POT. Despite this, no flow was achieved in the side branch. And the patient started complaining of chest pain. ST changes were also noted on the monitor. So operator decided to stent the diagonal. So what could be the next appropriate strategy? Anyone among the audience would like to answer? If we look at the quiz again, the highlighted portions are like a cheat sheet thing. The angle was less than 60 degrees, they are not equal in diameter, and we are following the provisional stenting. So we followed the decay crush. Another question, which of the following is a provisional stenting technique? So inverted decay is a provisional stenting technique. My take-home message is focus on key clinical insights which can be applied in clinical practice. Don't disturb the natural anatomy and flow dynamics. Bifurcation strategy must be planned according to its nomenclature, and even in primary PCI, don't leave suboptimal results. Thank you very much.
Can you display your angiographic image prior to stenting? Because I thought both vessels are not of equal size. Let's see it again. And secondly, you said we have decided to take her as a case. Can I just complete? You just said to take her as a case of STEMI. Why not high risk non-STEMI? There wasn't ST elevation. So even high risk non-STEMI can be taken as early invasive,
Yes,
within hour or as early as possible, just like primary PCI. So
Yes,
don't
sir.
have to justify it by saying that we
Okay.
decided to take her as STEMI.
Okay. Yes, sir.
Okay. Yes, sir.
So
Sorry.
this is a dual LED system. The issue is that the first LED terminates before reaching the apex. And the diagonal looking LED ultimately ends up on the LV apex. If you go back and display the images, you can confirm that.
Yes,
So,
it is.
and then I think when you had stented from the main vessel into the diagonal branch, it appeared to be a good result. And in a very thrombotic environment, we could have just stopped there and waited for, I think we had achieved a good result. There was no need to continue to be to a Q lot.
Okay, sir.
You could end up with just a provisional
It's
stenting.
in acute ACS, you try to keep things as simple as possible, maintaining TIMI-3 flow in all the territory. There may be difference of opinion in that, but that would be ideal strategy. Then you can come back again and stage and do other things. You can.
Okay, sir.
इसमें यहाँ पे डिस्प्ले कर सकते हैं वो एंजियोग्राफिक व्यू जो आप कर रहे हो?
The main concept है वो ये है कि she was just a 42 years old lady who had this lesion with dual LED of which उसके बाद जो है ये status किसी बोल में आपने दी को, how did you proceed afterwards? Because just it's not just a one-time treatment that the patient came, you stented the patient, let the patient go home. So now, keeping in mind the age of the patient, that she's just 42 years old, you have to keep her alive for at least 30 or 45, 40 years more. So आपने क्या strategy रखी treatment की, follow-ups की, rehabs की? That is what we have started.
One comment, if I allowed to. Everything was done very well. I don't have any question or reservation about the procedure. One thing which I wanted to highlight, that whenever we present such cases in an academic forum, we should anonymize the study. And the patient actual name or that should be not visible to the general audience. And ethical issues, this should not be visible.
Agreed.
That is a simple message. I hope you...
Regarding this case, actually, technically it has been done in a fairly good fashion, and as he mentioned that what should be the long-term plan to reduce further events and all that, definitely medical treatment is very important, and less stents and DCBs nowadays, rather than putting a lot of stents, that probably is a good strategy for all of us. Regarding the dual size of LED, we know that by definition LED will give septal perforators and diagonals. And if we look at the lower one, it is giving septal perforators but not any diagonal if we consider that the upper one is a diagonal. And the upper one is giving only diagonal, no septal perforators. So these are two LEDs basically. And they are, the more important is which is going all the way to the apex, and because it is supplying more area and the inferior wall and all that, sir.
I just think I am a very big disbeliever of a dual LED system. I mean, there's one septum which is about 1 millimeter across. We will have one vessel going on top of it. You can have another vessel which is like running around it. It may be running, it may be bigger. My feeling is that, you know, that long one is the LED, and this is an early septal which just travels down. It's going septals all along. So it's just a big septal. And there's you cannot have two vessels. Look at them, they're so wide apart. How can the two be traveling on the same septum? But, you know, Madam didn't take the iliocranial or something, but there's a feeling.
Yes.
The nomenclature can be anything.
Actually, septal perforators, because they are at perpendicular angle, actually, they perforate the septum. So if we look at this is going probably on the surface of the left ventricle, and then after the angioplasty, once the thrombus was clear, we could see a lot of septal.
You could see some small septal coming distally from the second one.
Actually, these things are very clear if you start looking at the CT. If you look at the CT angiograms of these arteries, then you will know what is a dual LED. Because then on
what
the
do you
CT,
see it on Faransa? Explain that.
You can very clearly see that there are two LEDs running parallel to almost each other. One looks like a diagonal, one looks like an LED. The first LED, which is in the interventricular groove, terminates before reaching the apex. And the second LED, which starts as, look at this, it reaches the apex. Look at the image now.
Yes, it is going all the way.
It's going beyond the wire and it's reaching the apex. That is why it is called
the second doesn't
this
have
is a dual LED
two
system.
septals. They get this. I'm not questioning it. It's supplying all. The first one is supplying all the septals.
Yes.
And it comes down. And if she had taken, I'm not saying you did something wrong, just the nomenclature and description. If you had gone iliocranial, that's the only time when you can see if it's running on the septum or not.
Yes.
Because sometimes you could find difficult to separate septals from the LED.
Yes.
So that's the only view where you can make out if it's goes away from the septum or runs on the septum.
Yeah, this particular view is
I think
looking like the second one, smaller one is going in interventricular groove, because you see all perpendicular septals are coming from it.
But it does not reach the apex. It terminates before reaching the apex.
Yeah.
And the second one reaches the apex.
Again, reaching apex is no criteria of calling it
I
an
think you
LED.
should read something more about CT. Sir.
Okay.
Only then you will come to know, sir.
Last time you said that
your
20 years
reason
ago.
for being non-believer is
let's move on to the next case.
You have not knowledge about the CT. I'll send you an article about it.
Yeah, I'd love to.
I now invite Dr. Vijat Lodhi, Fellow Interventional Cardiology at F4G Foundation Hospital.
Bismillah Rahman Rahim. My name is Dr. Vajat Lodi. Today I'll be presenting a case of when you take things for granted, the things you are granted get taken. It's probably not as exciting a case as my colleagues have presented, but it's something that emphasizes on something very, very basic. So this is a history of a 56-year-old lady who's diabetic, hypertensive. She's on regular treatment, fairly good control over comorbids. She has very strong family history of ischemic heart disease. Father had died of MI, and uncle had MI at the age of 52. So she presents to the A&E department with complaints of chest pain, which is typical in nature, associated with sweating. EKG shows precordial STT changes, echoes with an EF of 55 to 60%. Troponins are positive with 2.54. So again, the echocardiogram showing a fairly good LV, some STT changes in the anterior precordial leads. The next logical step would be to complete a checklist and then put it in the cath lab and do a diagnostic angiogram. We get a fair idea what we have to do, what's the plan. As the anatomy gets clearer and clearer by taking multiple views for this patient, we fairly know that what we are going to tackle, and the main issue is that we're going to tackle that LAD diagonal bifurcation. We calculate the patient's GRACE score. We take a Syntex 2. It's favoring cabbage. But with shared decision making, the patient, the family, they opt for using PCI as the revascularization strategy. And the choice of the technique was at the discretion of the operator, so it was decided that we would go with the provisional single stent strategy. So again, apicranial viewing showing the wiring, 3 workhorse wires, all placed, protecting all those major branches. Protecting the circ, that diagonal, and the LAD itself, pre-dilating with a 1.515 balloon. Apicranial view showing the predil with a 2x15 balloon. Alveocaudal view showing the predil dilation of the ostium, something that we do very frequently, a pot puff, just to give us some hint of how approximated and the sizing of the vessel is. We again going through the notion of completing a pretty standard angioplasty up till now. We confirm in different views, and it's followed by another pot puff check, and we stunt in the alveocaudal, and again try to nail that ostial LAD. At this point, the patient has no chest pain. She was doing fine, but we see that that diagonal is slightly pinched, and it was decided that we will recross into that diagonal and just do a low pressure balloon, a POBA, just to get the ostium better. So again, a 4th wire goes in, and we've taken a pilot 50, we've recrossed into that diagonal, we've ballooned it with a 1.515, and then escalated it to a 2x15 balloon. Then we get something like this. And now we've removed that jail wire, and we see some staining in that left main ostial area. Now, 2 things come to mind. Number 1, is it a dissection, or is it thrombus, for that matter? So the patient started dropping pressures at this time. She became very acutely unwell. We had to call in the anesthesia. We sedated the patient to calm her down, and if need be, we could intubate her. The patient had 2 runs of ventricular tachycardia, which was electrically cardioverted. Now, immediately call for help was initiated, and an all-hands-on-deck approach was taken, and the HOU then take over the case. In our case, it was General Sohail. The patient becoming very irritable and moving a lot on the table. We lost a few wire accesses. We then decided to engage the left main again on the preset that it looks more like thrombus than a dissection. Thrombuster, despite all our efforts, would not advance. We removed that 3rd wire. There was kinking. We could just not get that thrombuster in. So we could not deliver any balloon or wire. It would kink, bend, and it required quite a lot of force. During this time, we had taken 2 ACT measurements. One was about 30 minutes into the procedure with about 7,500 units of heparin, and the first ACT was 240, after which we gave her an additional 2,500 units of heparin, but our second ACT somehow came to 110 seconds. It was no flow. So what do? We took and mind you, we've tried everything to deliver something into that occluded left main, and we're not getting through. We took a leap of faith, and contrary to what the standard practice is, we removed everything. We removed everything, and we flushed our guide, and we could see a lot of thrombus coming out of the guide. So we were certain that it's not a dissection and we're dealing with probably catheter thrombosis. So we re-engaged. We've now rewired all our major vessels that we had to protect. We're doing serial echoes. This cine kind of shows the brief period of asystole that the patient had, and we had followed with 2 minutes of CPR with chest compressions. We then proceeded with dilating that LAD to get some sort of flow established. Maybe it will help with some, getting some relief to the patient. When we ballooned that LAD, left main LAD, we got a lot of streaming artifact. I think it was all thrombus-led, and a lot of thrombus had just embolized throughout the course of that vessel. And we then proceeded with doing a 3.5 38 drug-eluting from the left main to LAD and dilated the outflow of the same stent balloon. And then post PCI, the TIMI was about 1. So we then proceed with the next no-flow strategy, that is usually, go for a glycoprotein 2B3A, 10 micrograms per kg bolus. We omitted the loading dose, standard loading dose. Then plan was to keep her on glycoprotein 2B3 in infusions for the next 18 hours. At the same time, there's a TIMI flow, zero flow in that diagonal. Can be seen, should it be reattempted now? Because basically that became the stepping stone of this complication to begin with. So should we recross it in a crashing patient, or should we do the necessary and just cut our losses and leave the cath lab? So we then proceeded not to attempt that diagonal that was flushed occluded now. We proceeded with doing the TAP hybrid, sort of a bailout technique. After that, it kind of becomes pretty standard at what needs to be done. We recrossed, we then addressed that circ ostial pinch now. We recrossed into that. We performed our TAP. We did our kissing. We're doing POT all along the way. POT is now very important whenever you're, doing a complex PCI, especially with the left main. It helps with deliverability of stents and wiring and prevents the wires going behind the stunt struts. This was the final result, which was fairly good. We were happy. She became quite asymptomatic on the table. We were fairly okay that we've done a good job. Plan was to shift her to the CCU and keep her on glycoprotein 2B3A over 18 hours. She made an uninfilled for recovery, but the same night she complained of mild chest pain. Now, with so much going on, we were worried that something has happened again. The plan was to restudy her anyway, be it a bit earlier than planned. So is there a silver lining in this whole scenario? There certainly is. The patient went back to the cath lab, and we can see that diagonal is back. And it was a big sigh of relief, and the LV angio showed that her LV cine is pretty good, LV is preserved. So I was happy to report that she's doing well and symptom-free. So the take-homes are that always call for help, involve your seniors when in trouble, swallow your pride, always announce your ACT levels and the heparin dose that is given. Left main disease, IVUS is must in left main PCI, even to diagnose at times. Due to some technical issues, we did not have IVUS in this patient available. Always go in a case expecting the worst and always rehearse your checklist. And sometimes less is more. And I thank you for your time and attention.
Can you run again the angiographic view? Because I thought there was a disease in distal left main as well, along with it. And it was not just LAD diagonal bifurcation, some moderate kind of left main to LCX bifurcation as well.
Sir.
Can we have that view?
Sir.
I think the way the thrombus has formed, it was clearly a heparin, a malfunctioning heparin or inadequate heparin, underdosing, whatever, because the whole RT had become certainly thrombosed. It can only happen if there is underdosing of heparin.
Actually, but I thought that your proximal
She's lucky to be alive, I
landed
would
within
say.
the left main. Just want to see that.
Sir, I'm waiting for it to come on.
After that, everything
My own
started.
feeling was that we normally give 7,500 heparin, and in this case, I think the procedure was done by a relatively new guy, and he was taking too much time. I mean, AST has a certain time, and I think within half an hour you must finish. If you're going to go beyond half an hour, that was my feeling. So probably the procedure went very slow. And my own feeling later was that we should not have tried an osteal procedure in this because there was too much chance it would have been just a very simple left main LED. Yeah. And the other thing was that when you said we pulled out everything because the clots kept on coming back. So I took out everything and we replaced everything because the wires had kinks. So we took new wires, new catheters because I wasn't sure. Once we had this problem before also, we flushed it and the catheters, the clots came out. So if you have clots in the system, don't believe in aspiration. There might be more in the system. So you take everything out, you'll always recross, inshallah. But take it out and get new wires and new catheters, and invariably after 30 minutes, go on to 10,000. Yes, it is. Yeah.
Sir, do you have any comment regarding the hemodynamic support you used in that critical situation? Actually, once the patient was in shock and brady and all those. So what did you do? Did you?
I think if you start focusing on the hemodynamics, you're going to get in trouble. The best is to give shots of inotropic support and get anesthesia, and so in case she arrests, you can have the top end be looked after somebody. So I mean, there's not enough time to put a balloon pump and those things. You just need to move very quickly and get the flow going.
And you see your even osteal LET and distal left main is all disease.
Yes.
Just compare it with your circumflex.
Sir, we agree with that.
So ideally it should have been left main too.
Yeah, sir, we agree with that. We had this discussion, sir, that it was probably not a very good idea to nail that ostium and probably come into the left main.
It just shows the stent, your stent landed within that disease segment, I think, within the distal left main.
And Farhan, do you remember a few months ago, there was a batch of very bad heparin,
yes,
which was very thrombogenic.
We all actually experienced that.
We all experienced, at least in Rawalpindi, Islamabad area, I don't know.
Yeah. Sir, actually, either it was not working, either it was
Sir, or a long procedure, too long a
procedure. Excellent case, sir.
So E3 has to be done very regularly.
Sir, it was an excellent case with excellent uneventful outcome.
Yes. Disrupted.
Sir, actually, it's reported cases of heparin resistant. Actually, this was a case of heparin resistant, and the cases are less reported and most of the time neglected in the cath lab. The best alternative in such cases are to switch to Clexane. Enoxaparin is more effective IV in such cases. We have
in this patient, when they removed everything out, it was smooth sailing afterward.
Vahid Saab, you know, the guidelines says that if you're on Clexane, you want to do a PCI, just give heparin. You can do it with bivalirudin and, you know, what's the third one? You can do PCI with those, but nobody says to do PCI with Clexane.
In such heparin-resistant cases, sir.
Yeah.
Sir, there's a newer data that if your patient is already with subcut Clexane admitted, you shift him to the cath lab, you don't need, if given within the last 8 to 12 hours, you don't need to escalate with unfractionated.
At least 2 dosages.
2 dosages, yeah.
So that's just 1 dose. Yeah.
Yeah, and sir, what about the, sir, master's opinion, what should be the mode of giving heparin? Because we give it from our cannulas usually, and there's evidence to support, or people give it from the sheets. The cannula could always be dodgy. You'll not find out. The sister might not report it to you that it's blocking. It will go through. So there's always a debate whether to give it from. So that's one question that's always been on my mind, and I've got different answers from different operators every time. So this is
Sir, I want to ask, when we were we were thinking that it is the thrombus, not the dissection, and in this case, there was a lot of post-ballooning after that. So my question is, what can be option if we just given and medicines instead of doing balloonings, because ballooning can cause more no reflow and.
Dr. Saab, it's a good question. The picture isn't showing a lot, but when we saw it, we could see dye all around a spot, suggesting that there is the section tends to be more linear, and when in one view it was like something there with dye all around. And when we opened the catheter, the clot started coming back. So that we showed that there is a clot going there. And, if you have such a thrombus sitting there flowing, you can't just leave it to chemical. You have to mechanically remove it because there's no flow. Patient is collapsing. So I think if we had not moved earlier, there would have been disaster for the patient.
It wasn't just a focal clot. It's all over clot. Even the circ ostium was filled with clot as well. So it's looking like something iatrogenic happened and dislodged the clot in whole system.
It is actually left ventrally. There is a 2 to 3 million part of the stent is in the middle.
Thank you, sir.
Our next presenter is Dr. Wajid Sadat from AFIC.
Assalamu alaikum. I am Dr. Muhammad Wajid Sadiq, resident cardiology at AFIC and NISD. Today I am going to present an interesting case, chest pain with acute ST segment elevation. So this is a case summary of a 50-year-old male, previously known non-comorbids. He initially presented in the non-PCI capable hospital with sudden onset of chest pain, which was cardiac in nature. He was hemodynamically stable and physical examination was unremarkable. His 12-lead ECG was recorded, which showed acute ST segment elevation in the inferolateral leads along with the reciprocal changes in the chest leads. So the diagnosis of inferior wall MI was made and PCI capable hospital was distant. So they started the streptokinase infusion. And during the infusion, patient remained hemodynamically stable and his symptom disappeared. And post-thrombolysis ECG was recorded, which shows successful thrombolysis, and his ST segment amplitude was settled down, and patient was also hemodynamically stable and asymptomatic. So they kept admitted for observation for 24 hours, and then next day they transferred the patient to the AFIC. At the presentation of AFIC, patient lab parameters was in the normal range. His 2D echocardiography was normal. So we admitted the patient for elective coronary angiography. So this is the angiogram of the patient, which is showing almost normal left coronary system, and there is no significant lesion in the right coronary artery, although it has some minor irregularities in the mid-course. Another view. So we decided to discharge the patient. While his discharge paper was being ready, patient again complained of chest pain. It was again cardiac in nature. IV analgesic was given and 12-lead ECG was recorded. This was his baseline ECG, and next ECG after the appearance of the symptom, which is again showing acute ST segment elevation in inferior leads. So we initiated the primary PCI protocol and shifted the patient to the cath lab. Again, his left system was normal and unobstructed, and in his right coronary artery there is a fixed stenosis, almost more than 90% in the distal RCA.
I think there were haziness in the previous angiogram as well at this region. If you just look on to the previous.
Sir.
Yeah. There was heaviness in this bifurcation.
Sir.
But it was looking like recanalized vessel with some haziness there, clot sitting.
I don't see anything.
अभी पिछला दिखाता हूँ.
पिछला दिखाओ.
जो first RCA view था वो दिखाइए. ये वाला first वाला. इसके बाद वाला जी ये.
कहाँ है? कहाँ है?
एक व्यू मुझे एक
और
है कोई.
पीछे जा यार, शायद कुछ और.
इसमें एक
वो दूसरा देख लिया ना तो इसलिए लगता है.
नहीं मुझे एक व्यू कोई ऐसा नजर आया है.
नहीं अगर फवाद साहब को नजर आए तो I know he's got great eyesight.
Maybe an OCT would have revealed the erosion there.
कुछ और there is something.
मुझे एक किसी व्यू में.
अच्छा आगे चल यार.
पता नहीं. चलें आगे चल दें. लेकिन बंद तो हुई है बाद में वहीं पे. ये अच्छा this one.
हाँ. नहीं ये तो अब तो
इसी की बात कर रहे हैं सर.
कोई बात नहीं.
Sir, before we put the wire into the right coronary artery, our consultant decided to give him the nitroglycerin.
Okay.
After giving him nitroglycerin, you can see the magic.
Please don't tell me it is
Okay.
a failure. ये तो बिल्कुल ठीक नहीं. कुछ बेहतर हो नहीं वैसा ही.
This is a pre-nitrate angiogram, and this is the post-nitrate angiogram.
Great.
It was completely disappeared, and patient was saved from the unnecessary stenting.
अगर दोबारा हो गया.
So I am skipping these sides.
अगर दोबारा हो गया.
My take-home message is whenever any patient comes with chest pain, it is better to give him nitrates before wiring the coronary artery.
Before even giving SK, because he received SK as well.
Sir,
Previously he received streptocarditis.
there was, it was a presumptive diagnosis. There was no facility available to see the coronary arteries.
But waiting just 10-15 minutes, observe, इतना तो लगता है nitrate देख के एक ECG repeat करना. Just ECG के साथ ही SK शुरू करना.
Sir, it was inferior valve MI and nitrates was
SK तो ECG पे ही होता है ना. So if somebody saw inferior MI, SK देखना was really relevant, ना?
मगर ये पहला जो केस था ना, the first ECG, it appears that this was Prince-Metal's angina.
You see,
And
also
this was a
In
vasospasm.
retrospectoscope, it was Prince-Metal.
No, it was
but
a
उसका जो
vasospasm.
streptokinase बनता था ना.
Vasospasm, and it was transient. What were the enzyme levels?
Sir, enzymes were normal.
Enzymes were normal. You see, that is the thing. So this was Prince-Metal's angina.
This is
यार एक जवान बंदे को MI हो गया, आप उसको छोड़ देंगे कैद के बगैर?
Risk assessment, it's good to get.
You will look for an excuse to do it, and everybody would do it.
Actually,
Please kindly speak to the chair.
Sir.
Please either speak to the commandant or speak to the chair.
Excuse me. If you see the first ECG,
I think
it has typical ST segment elevation and
to-
reciprocal depression, number one. Number two, whenever a patient comes to the emergency, he or she receives nitrates. Nitrates are always given when the patient enters the, so the patient has received nitrates.
Maybe.
And after that, the ECG shows these things. And then SK तो बनता था.
Okay.
सर ये कैसे है कि आप ना डिपेंड्स के कौन सा डेटा देख रहे हैं ना. There's a lift trial long ago कि people who were successfully thrombolized became totally pain-free, no evidence of ischemia. They were cast on trial, and 13% is severe surgical disease. So देखिए मैंने young person दे हर कोई ये कहेगा ischemia driven, pain driven ऐसे करें, but in the end everybody would do it.
No, sir.
और हर मुल्क में होगा, हर शहर में होगा.
Nearly 20 to 30% spontaneously revascularize. और ये probably this
और
was.
जो thrombolize भी हो जाते हैं successful, 70% re-occlude.
और इसमें मेरा ख्याल है चूंकि enzymes raised नहीं थे, this was a classical example of Prince-Metal's angina.
No.
And then you also have, you can have it without a lesion, and you can have it with a lesion.
No, important thing is, once you have sent him back home, don't give him beta blockers. They promote more Prince-Metal, and Prince-Metal is worse in the early hours of the day when the alpha tone is very high. When you block beta receptors, the alpha tone is relentless. So you avoid beta blockers.
Enzymes also take time to rise.
I think it was a good decision in the first place to do an angiogram. It was indicated. And the diagnosis was...
Great case, Dr. Saab.
You do that in special population, people who actually fly planes, or they are to be re-employed at places which they are likely to get hypoxic. Like our patients, they actually go to high altitudes. So high risk occupation. So the point of doing angiogram in this patient was actually to define his future employment also. So we have here. Yeah, he's a soldier. Yeah, that's the point.
No, it's
देखिए
not
मैं
just for
इसमें
that
एक और
reason.
बताऊंगा
There is a strategy pharmaco-invasive where you do cath in patients with successful revascularization as well. After 3 to 12 hours, you do that. You can do that.
देखिए एक और चीज़ देखें कि हॉलैंड में every place is half an hour away, within half an hour of a primary PCI center. England में any time you call an ambulance 999, they'll respond and bring you to the hospital within 18 minutes. That's the mandate. यहाँ पे इसको छोड़ें, कोई कोटली चला गया, कोई maybe कहाँ चला गया, उसका travel time कितना होगा? It'll take him days to come. And people from Kashmir which we deal, वो 20,000 रुपए की गाड़ी करा के आते हैं, 4 बंदे आते हैं. So उन पे guideline आप कैसे apply करेंगे? So guidelines are by the
guidelines में ये चीज है कि
guidelines are
जो asymptomatic stable patients में before discharge we must do an angiogram. ये latest guidelines में है अभी वैसे ही है.
Even with successful reverse.
There was a real procedure, drip and ship, कि स्ट्रेप्टोना का लगा के शिप कर दें इसको, drip and ship.
जी बस वो within 3 hours आपने एंजियो नहीं करनी है. 3 hours के बाद सक्सेसफुल रिवर्सलाइजेशन में 3 hours to 12 hours क्योंकि रेजिडुअल आपको नहीं पता है ना, रेजिडुअल एटी भी हो सकती है. दैट ईसीजी एंड रिवर्स नॉर्मलाइजेशन मींस STEMI 3 फ्लो मेंटेनेंस आफ्टर रेस्क्यू. इट डजंट मींस यू हैव न्यूमन ऑफ एडिक्वेट लाइक risk free.
But after 48 hours you might give a little time, but लेकिन stratify तो करना है. अरे हर जगह के अपना प्रोटोकॉल बनेगा.
Please welcome Dr. Waleed Babar, Fellow Pediatric Cardiology at Armed Forces Institute of Cardiology.
I am Dr. Waleed. I'm a fellow in pediatric cardiology at AFIC, working under the supervision of Birde Khurram Akhtar. And the topic of my presentation is tackling coarctation of aorta, while at the same time avoiding obstruction of the left subclavian artery and neurointervention for perianeurysm. So our patient, Jamil, 44 years of age, he presented to AFIC with complaints of left-sided chest pain and palpitations. He was labeled as having hypertension for the past 3 years, taking a combination of amlodipine, valsartan, and hydrochlorothiazide. There was no history of ischemic heart disease or diabetes mellitus. His ECG upon presentation was unremarkable. His tropi as well as CT angio for coronaries was unremarkable. His blood pressure as recorded in both the upper limbs and the lower limbs revealed a difference in the systolic blood pressure of more than 20 millimeters of mercury between the upper and the lower limbs. He then underwent 2D echocardiography, although this is not a very good image, but you can see the elysing of the color right next to the region of the left subclavian artery, and this area had a gradient of 60 millimeters of mercury across it. So the patient then underwent a CT aortogram, and as you can see, there's a discrete area of coarctation which is lying right next to the region of the left subclavian artery with post-stenotic dilatation. So this was the dilemma, that the coarct segment, it was lying very close to the origin of the left subclavian artery, and we were of the view that if we place a covered stent in that place, we would eventually go towards obstruction of the left subclavian artery. So some other images which show the from the CT angiogram, and as you can see, the coarct segment measures up to 5.1 mm. The transverse arch, it measures 17.3 mm. The origin of the left subclavian artery, it measures 16.3 mm. And the descending aorta, it measures 37, the aorta post the coarctation, that is the dilated part, it measures 37.1 mm. So the AJ states that in patients with significant native or recurrent coarctation and hypertension, endovascular stenting or open surgical repair of the coarctation is recommended. In addition, the AHA also states that in patients, especially in adult patients with coarctation, it is better to go in to screen for CT, for intracranial aneurysms via CT or MRI. So, keeping all of this in mind, a joint consensus was made between the pediatric cardiac surgeons, the pediatric cardiology team, and the vascular surgery team. And it was decided that the patient would undergo a transcatheter closure, transcatheter stenting of the defect of the coarctation of the aorta, and if the left subclavian artery gets obstructed, they would apply a graft between the left subclavian artery and the left carotid artery. But before we could proceed, following the guidelines, we advised the patient to undergo a CT angiogram of the coronary vessels, of the cerebral vessels. And as you can see, this is the digital subtraction angiography, and you can see the circle of Willis. And this pointer is not working, but I'll forward this. So, as you can see, the red pointer, this is a small aneurysm at the site of the anterior communicating artery. So, after all this, again a multidisciplinary team meeting was held between the Department of Structural and Congenital Heart Diseases at AFIC, the Department of International Neurology, and the Department of Vascular Surgery. And it was decided that the patient would undergo coiling of the perianeurysms, and this will be followed by stenting of the coarctation. In addition, it was also decided that we would uncover, we usually used cover stents for the coarctation stenting, but it was decided that we would partially uncover the stent based on the measurements on the CT angiogram, so that we would avoid obstructing the left subclavian artery. So, as you can see, the perianeurysm is coiled in this image. Again, a CT angiogram image, and you can see the length of the stent which we intend to place was 45 mm, and the 14 mm measurement as shown on the CT angiogram. This is the area of the stent which we intend to uncover. So the strategy was to uncover the first 15 mm of the stent. Pointer. So this is the 14 mm region which we wanted to uncover, and as you can see, the length of the stent which we wanted to place was 45 mm. So we used a covered CP stent, 8 zig 45 mm. The part which was to be uncovered was measured with a caliper, and as you can see, the stent is being uncovered. So here you can see that the 1/3 of the stent is being uncovered. That is 15 mm of the stent is uncovered. So we went in via the right radial and the right femoral arteries approach. 2 pectoral catheters were kept, one in the transverse arch and one in descending aorta, and simultaneous angiograms were taken. This is the area of the coarctation. Afterwards, a wire with a 6 French JR catheter was passed via the right radial artery, and as soon as the wire crossed the coarct segment via the antegrade approach and it came down into the descending aorta, it was snared from the right femoral artery. Again, another 6 French JR catheter was passed from the right femoral artery and to cross the segment of the coarct. The wire, initially we used the trauma wire that was then exchanged with a super stiff wire, and a 14 French balance sheet, that is the delivery sheet, was passed over the super stiff wire. So as you can see in this image, with the Mullen in place and with the stent in place, you can see good flow across the left subclavian artery. Finally, measurements were taken again so as to confirm that our initial measurements, they would coincide with the measurements taken on the CT angiogram. And now the stent is being deployed. So we used an 18 mm bib balloon to deploy the stent. And finally, with the stent in place and an angiogram taken, even though you can see that some part of the stent is covering the left subclavian artery, but as this stent was uncovered, the proximal 15 mm was uncovered, so you can see good flow across the left subclavian artery. So there were no complications post-procedure. The patient was on dual antiplatelet therapy for 6 months. His blood pressure on follow-up is 125/75 millimeters of mercury, and we intend to do a CT autogram at 1 year post-procedure. Thank you.
Khurram Sahab, that was really a remarkable case. Is तरह पहले भी किसी का experience किया? I mean, it's such a simple concept because, you know, how did you, have you done it before? Yeah, you guys came up with it on the spot. Mic देंगे?
Hello. Thank you, sir, for the nice words. Sir, we actually आपने जो हमारी meeting बनाई है Thursday को, we all get together, we put our brains together, and इसमें we involved the neurosurgeons, we involved the vascular surgeon, and he was pretty confident that it would not, even if we jail the subclavian artery, there is enough of collaterals and the subscapular plexus. Actually, a lot of flow is there, so even if you jail the subclavian, but we were not very comfortable with the fact. So we had actually planned to carry out the procedure in the hybrid lab. But then it turned out that the plan became this way, that we do our case, and if there is a problem, then we would take him, the vascular surgeon would. But we uncovered the first third part of the stent, so there was no need to go to the vascular surgeon.
So what is usually an impact of uncovering a stent in long term in terms of stent? I don't know about these things. So is there any harm of uncovering stent?
Agar sir, if you read the earlier literature, stents were deployed without cover. It was only with passage of time that covered stents became available, and they provide more security. That in case you break the wall of the aorta, then you have something to hold on to.
So it's just a precautionary for sake of
rupture से बचाने के लिए
perforation or anything of that kind.
Sir, even for a covered stent भी डाल रहे होते हैं, we have another covered stent as a backup.
If
yes, sir.
God forbid something happens.
Sir.
Khurram Sahab, we know FIC guys है, हमने T-war काफी किए ना. T-war के अंदर covered होता है, उसके जो आखिर में breaks होती हैं ना, वो आगे होती हैं, they're bare. So what you do is कि you breaks up subclavian के cross कर लेते हैं. And so it's the same concept के, and nothing happens. The flow just continues. It's such a large lumen, so it should work very well because हम लोग तो बड़ा वो Endurant is a much more expensive device. उसके पहले breaks deploy करके you can jail the subclavian unless के वो involve वो aneurysm में. Then you got to go beyond it, and then you got to give a bypass कराना पड़ता है. It's a great concept.
Actually, I saw once in a gym meeting, in a Milan meeting, Antonio Colombo was doing. It was a stent, covered stent from ascending aorta across the arch down to the thoracic aorta, and there were fenestrations against those vessels coming off that arch, and he then put a balloon wire and then opened it with a low pressure, and that was marvelous. I haven't seen it done.
That's known as a FEVOR, a fenestrated EVOR.
Right. Okay. Right.
Up to.
I'm Professor Najam. The same case we did in the RIC also. I just want to tell, this is always a challenging, and it's all depend upon your measurements.
Sorry, अपना तारुफ कराएंगे फिर से?
I'm Professor Najam, a pediatric cardiologist from RIC, not working in children now.
Okay.
I'm just telling you about that I have also did same cases, and whenever you did the coact stenting, it's always challenging because the measurements is very important in that case. And same we did whenever you have coarctation just adjacent to the subclavian to prevent it, we have to half covered, partially covered, and partially covered stent basically pretend from the dissection, because if you look at that, the narrow point is is quite tight coarctation. That was for that protections. It's better, and he did excellent job for that. And for he also prevented the jailing for the subclavian also in this case. It's all on the measurements, and it's all depend upon how you can approach that. That's why I'm telling you that this is in routine for the congenital fellows.
And we must appreciate Dr. Waleed's presentation. Dr. Waleed is son of Dr. Yasmin Kal Yasmin. Okay. Yeah, he's a brilliant I'm sure Khurram would have announced that he's a great physician and doing very well, mashallah.
Thank you, sir.
A big hand.
Thank you, sir.
An excellent case of multidisciplinary team approach. For our last presentation, I invite Dr. Fasiullah Khan, Fellow Interventional Cardiology at AFIC.
Bismillahirrahmanirrahim. I am Dr. Mohammad Fasiullah Khan, Fellow Intervention Cardiology in AFIC, Rawalpindi. Today I am going to present a structural heart case, TAVI with difficult access. First, history and examination of the patient. An 85-year-old male, Nasir Ali Jan, he was a known case of diabetes and hypertension. He was an ex-smoker with history of PCI to LCX in 2019. He presented in OPD with angina CCS class 2 and dyspnea and YH class 2. Examination of the patient revealed ejection systolic murmur in aortic area with radiation to carotids. Lab data showed within normal limit with eGFR of 64.4 ml per minute. There was no history of syncope, stroke, ITI. ECG of the patient was unremarkable except few VPCs. There was no STT changes. Echo done which revealed normal size chambers with mild anteroseptal apical infralateral wall hypokinesia with moderate LV function. LVEF was 40%, mild concentric LVH, and there was severe aortic stenosis with AVA VTI 0.5 centimeter by continuity equation, and mean PG was 64, peak PG was 107, and Vmax 5.1 meter per second. There was mild to moderate AR as well. Mild to moderate AR, and there you can see the pressure gradient on the right side. Coronary angiogram done. LMS was double barrel and LAD has diffuse calcified vessel with diffuse critical disease in mid to distal. Proximal portion was spared. And L6 was dominant vessel with moderate to severe disease in mid-course. RC was non-dominant and total from mid-course. It was labeled as triple vessel coronary disease, but we managed triple vessel coronary disease medically because there was poor landing zone for the cabbage, and also due to heavy calcification and diffuse nature of the disease, we were not amenable to PCI to this patient. Although risk score fall in the intermediate risk category, STS score was 6.5%, Euro to 5.8, and STS ACC TAVR in hospital risk score was 3.2. So for aortic stenosis, we had two options, surgical aortic valve and trans-aortic valve implantation. Keeping in mind is surgical risk, he fell into intermediate risk, but as keeping in mind his age, more than 80 years of age, TAVR was planned as first choice for this patient. So decision was triple vessel was managed medically, TAVR planned for severe AS, and workup for TAVR done. First cardiac CT, cardiac gated CT with femoral runoff done. On CT parameter, aortic annulus was 28.4. Ostial height was adequate. Ostial height was well above the 10 millimeter, and sinus of Valsalva. Sinus of Valsalva diameter and height are within normal limit, adequate diameter and height. And annulus diameter is, mean annular diameter is 28.4 mm. If you see on the femoral vessels, so right femoral vessel has quite calcification, severe calcification. Here you notice severe calcification. And common internal iliac, internal iliac and external iliac. Common external iliac has relatively lesser diameter than the femoral vessel, and there is a lot of calcification as well. But on the left side, external iliac level, it is blocked, totally, completely blocked. So you can see the annulus diameter 28.4 and sinus of valsalva diameter 38.5. Ostial height are well above the 10 mm. You can see the calcification on the arch of aorta as well as on the aortic valve. Here you can see the external iliac on the right side is relatively lesser diameter, 5.8, less than 6 mm. Here. And also calcification is somewhat tortuous as well, a bendy vessel. On the left side, it is totally occluded at the level of left external iliac vessel. And a calcium extended up to the abdominal aorta as well. You can see here. So as per patient evaluation, 34 mm evolute or bioprosthetic valve, whatever was selected for this patient. And femoral approach was femoral artery was heavily calcified and bendy. Femoral cut down was planned and vascular surgeon was taken on board. This is femoral cut down done successfully. First, we tried to pass 20 front centered sheath, but due to heavy calcification and bendy nature of the disease, we were unable to pass the 20 front sheath. We tried to manage it, but it got stuck at the level of external iliac. You can see the movement as well and high calcium level. This is higher calcium. Then we tried 14 French sheath. 14 French sheath was successfully passed, keeping in view that we might get enough time, enough space to carry the 20 French sheath. But again, we were unable to pass the 20 French sheath. Then we did the pre-dilatation of the external iliac vessels with 7 into 33 mm NC below. We even had a supportive wire, Lunderquist wire in the LV and tried to track down the 20 French sheath, but again was unsuccessful. Then we tried to enter sheathlessly, sheathless with valve inline sheath. But it got stuck at the same point, at the external iliac on the right side, due to heavy calcification. Then we shifted to the axillary approach. Axillary cut down was done successfully. And similarly, we tried to pass the 20 French sheath, but was unable to pass. And again, we tried first 14 French sheath to make a space for the 20 French, but again 20 French, this is the 14 French sheath that is coming. But we were unable to proceed with 20 French sentence sheet. Eventually, here again we tried sheathless entry with evolute valve, and we were successful in deploying the valve. This wall deployment. There is successful deployment of the valve, but valve remained under from the lower side here. So post dilatation done, and eventually final result was very good. Then we close the vascular closure done on the axillary side, and the patency of the subclavian axillary artery checked. This is the final patency of the axillary artery after closure. Then on the right femoral closure, patency of the right femoral done. There was no leakage on both sides. And thank you.
That was really a wonderful case, and I think people have employed different approaches. In fact, they used to do apical approach also at one time, which found that result wasn't good, but axillary is a very good access. There was a case report of somebody doing it through the carotid also. So it's a great case, wonderful.
Certainly success at the end after so much hiccups. But just one theoretical question, a person who already has severe 3VD with nidus of ischemia, failure, everything there, just taking care of just putting in a valve, how sure you are that he is going to get rid of his symptoms?
Sir, patient.
So this patient was an 85-year-old gentleman, and we discussed in detail regarding his coronary angiogram. So most of his disease was in distal LAD, mid to distal vessels. So that's why we thought that probably medical management was more appropriate in this patient as regards the coronary artery disease. And if we correct the aortic stenosis, most of his symptoms should improve. And whatever residual symptoms he still have, we would probably manage it on medical treatment. Because considering his age, his mobility won't be that much according to his age.
I think a very, very well done case of TAVI. Brigadier Nadir, in patients who are a low risk, how is TAVI equated with SAVR? Because now the data is coming that you can do it even with the low risk, and it is same as in the surgical replacement. So I think that it should be done also in the low risk group, number one. Number two, even in those patients who have a moderate stenosis, not necessary to have severe stenosis before you put in TAVI. But I think it is also in cases where you have a moderate stenosis, you can do it even there because the benefit will be there. What really happens is as it becomes more severe, there are changes which occur into the myocardium, and that is going to affect it also. So I think it is better early than late.
This is always a dilemma whenever you are treating aortic stenosis as what is to the optimal time of surgery. Many of these patients have severe disease and they're asymptomatic. And it is still not recommended to proceed, but trials are on their way in which they are considering the subgroup of patients that you have mentioned, that some have moderate disease and some have severe disease who are asymptomatic, that should they be treated or not. So there is a trial going on at present which will sort of decide whether...
I think once they become symptomatic, irrespective of the fact that it is severe or moderate, symptomatic aortic stenosis, you have to operate in these patients.
Absolutely, sir. Absolutely.
Yeah, another thing about comparing SAVR with TAVR, the issue with doing TAVR in a very early age is that you're going to jail the coronaries. So now the new devices coming have a wider gap across where the coronaries are, because that's the real issue, that you need to gain access to these young people who will have coronary arteries later. And if you jail the coronaries, it's going to be an issue. The other is that for some reason, this tissue valve works much better in the TAVR than in surgical patients. And of course, there's always possible doing valve and valve later.
Sir, I think we must start for TAVI as it is coming up now, and with even newer valves which are being brought up, I think it is much better.
Sir, I think we must not forget the influence of definitely the industry when these trials come in force. And we know initially these trials were successful in patients who were deferred for surgery, and ultimately then intermediate, now low risk. But what General Sohail has pointed out, because we are seeing a lot of patients, because we are doing TAVR for last 5-6 years. So now once a patient comes to us with STEMI, then it's very difficult to deal the coronary, that's a life-saving procedures. So ultimately, when you increasing population of the patient who has TAVR, then there are a lot of challenges in future for dealing coronaries, number one, and these valve degenerates, so you have to put valve in a valve. So still there are a long way to go when we can
So conclusion, we are lacking long-term data right now.
Yeah, definitely.
You also remember it's an industry-driven thing, early and modern. Industry-driven trials. They are
Sir, I would very, very humbly beg to differ.
Industry-driven, yes, but I
it's
think
patient-driven. People don't want to have surgery. They are insisting on getting towers at a younger age. It's a patient-driven, and so that's why there's a big niche.
We are talking those asymptomatic and early.
not
Not asymptomatic.
Not
there's
asymptomatic.
Yeah,
Symptomatic.
symptomatic.
But low to moderate kind of thing.
You can have symptoms at different levels of stenosis, which may be difficult. Sometimes it's difficult to assess the valve. One must remember that aortic valve is like a 3-star. It becomes stiff. It's not like a circular which you can measure like in a mitral valve disease. So you've got to be very careful about the gradients and all.
It has been a long debate between Sever and Tever, but especially when you talk about low-risk subjects, I don't think we have enough data that you go on putting, you go on doing TAVI in low-risk patients, and especially in the younger population as well. So, like just we were talking about, they might
Harun, there's a
other
recent
complications
paper.
later on.
There's a recent paper.
I know, but the data is still not so long.
But I think
it's a short data.
the emphasis now is becoming more and more towards TAVI.
So there's another thing happening. There's some professions you cannot be employed with being on warfarin. So if a young man has an aortic valve replacement with a metal valve, he'll be in warfarin. He can't fly and do a lot of other things also. So many of them are getting a tissue valve with the anticipation that when it gets stenosed, they'll have a valve in valve.
Sir,
I've done 2 pilots. They had a severe aortic stenosis, severe disease. We did a multivessel stenting, and then they had a tissue valve, and they continue to fly, and they're very unbothered that at least they like.
Sir, as far as the guidelines are concerned regarding the low risk aortic stenosis cases, the guidelines are very clear. If there is severe symptomatic AS and if the age is more than 65, it is a class 1 indication.
Sir, the main thing regarding this TAVI is the durability of the valve. The day we have a valve that can work for 30 years.
These 20, 30
so
years.
this valve will be as good as...
I doubt if you'll have a valve working tissue valve 30 years, you can have valve in valve. I think that's going to become more common.
Maybe.
But even then, that at least long-term data, comparing both surgical intervention and, Chief, यही चाहिए हम, मैं यही बात कर रहा हूँ. I think our moderator really...
ये जो है ना, valve in valve, you even have that now.
Running the show within the time.
That is also good. I think
So we are
that's not a
almost
contraindication कि time 10 साल है, 12 साल है.
Fasibhai, great case.
I thank our esteemed panel of guests and our excellent presenters for today's academic discussion. I hope these academic discussions help further a shared goal of excellence in patient care. Thank you, everybody.
I would request everyone to please come back after Maghrib prayer for the inaugural session. Thank you very much.